Well, based on the data from IPAS a number of years ago and the subsequent study, there's no doubt that we have to use first-line EGFR TKI. Previously, the drug will include gefitinib and afatinib, and lately that we have to include afatinib into the choice for the first-line EGFR TKI. So any one of the three are potential drug that we should use in the first-line setting. So LUX-Lung 7 is a randomized phase 2b study that attempts to compare afatinib with gefitinib with patients with EGFR exon 19 or 21 positive. So the statistical is not actually estimated for sample size. So they have 3 primary endpoints, including progression-free survival, time to treatment failure, and also overall survival. So in the ESMO Asia this year, only the first 2 primary endpoints, including the progression-free and the time to treatment failure, were included in the presentation. Well, it is the first study that ever demonstrated a significant difference between the first generation and the second generation EGFR TKI. The strength is the fact that it is a head-to-head comparison, which actually we did not have in the first-line setting. There was one Japanese study. It was on an unselected population with a retrospective EGFR mutation assessment and also on second-line. But so LUX-Lung 7 is the first in the first-line setting that we compare head-to-head between afatinib and gefitinib. Now, gefitinib, in a sense, is that had been a standard drug in Asia, and also recently approved it in United States as well. So, in a global scale, it is actually accepted as one of the standard treatment. So, I have no problem whether it's going to use gefitinib or afatinib as a control arm. I think either are feasible. As a matter of fact, the comparison of the afatinib and gefitinib had never been demonstrated any significant difference. Now, the hazard ratio is significant with actually a significant p-value. The only curious thing that we have to be notable to is the fact that the median is actually 11 months and 10.9 months. So in other words, is that the separation of the two curves occur almost after 8 or 9 months of being on the drug. So we do not actually understand the mechanism entirely why we have this kind of shape of survival curve. However, a positive study is a positive study, so it demonstrates a improvement. But then whether the improvement is substantial for us to change the practice completely, that would be debatable. So now if I have to look into the potential explanation, then we may have to consider whether there is some degree of T790M inhibition with the second generation that occur on the later time, so such that we may delay the occurrence of T790M. However, without rebiopsy at the time progression, we cannot prove this hypothesis one way or the other. So that's one potential explanation in this regard. But certainly at this moment, I would not have any so-called definitive explanation why we observe this phenomenon, that no separation for the 9 months and then separated subsequently. Personally, I'm not a big fan of TTF, time to treatment failure. I don't think it provides too much information that may change my practice. I still like the more objective criteria of using the progression-free survival, especially in the LUX-Lung 7, it was actually independently reviewed. Because when you stop the treatment, time to treatment failure, that may be due to toxicity or due to the subjective opinion of the doctor. So it's not really something carved in stone as a standard when and why you stop the treatment. This is also curious in a sense is that the response rate of 56% with the gefitinib is atypical because there's many randomized studies that had already been reported. And so this is considered to be one of the lower response rate compared to other data. So and also on the other hand, the 70% with afatinib is more typical of what would have been reported in most of the TKI, including first and second generation. So you can say, yeah, there is a bit of difference, but there are substantial historic data to show the fact that the response rate is actually not in the range with the first generation TKI. It's a good question. Of course, we are still based on a hypothesis as the data is not available yet. But the difficulty is the fact that we have prior data from LUX-Lung 3 and 6 suggesting of overall survival benefit exon 19. So it would be very interesting and important to see whether the same story carry out in the comparative study. So if there is within the comparative study, exon 19 showing overall survival benefit, which confirm the pool analysis from LUX-Lung 3 and 6, that would be a very strong story. So I certainly look forward to the data to see if there is any difference in the overall survival, especially in the exon 19 subgroup. Well, just like anybody else, quality of life is important. But in terms of the TKI in general, the quality of life actually are quite good. I mean, with the first generation TKI, we have used it for 10 years. We're very familiar with the toxicity. Skin is the issue. Second generation TKI is a more potent TKI, so we expect toxicity to be a bit higher, which we have seen in terms of skin toxicity, mucositis, and diarrhea. However, if we kind of pay attention to it and manage it ahead of time, I think it's still manageable. But obviously, some patient may have very aversive so-called as psychological effect to skin rash, then we really have to discuss with the patient the impact of such. So I think there's no hard formula, but everything has to be discussed with patient in great detail. All right. So there are the skin toxicity and diarrhea, which is more prominent with afatinib. But on the other hand, the hepatotoxicity is actually a bit more common with gefitinib. Which is more important? Well, for the patient who don't have the hepatotoxicity, then it's not a problem. But then for the patient who has the hepatotoxicity, it is reversible, and then we can stop the drug to change the other. So whether this will actually immediately change the fact how you choose the drug is debatable. Because, in a way is that you cannot say that there are actually, a 5 to 6% chance of hepatotoxicity compared to less of than 5.6% chance. That's why you do not choose the drug. It's not actually the best approach to the situation. I think everything has to be explained to the patient, and then the patient do contribute to this final decision on the drug that's suitable for them. I think, as I mentioned earlier, this is the first randomized study that had head-to-head comparison that give us some idea between, as a group, second-generation TKI and first-generation TKI. And so it does give us a signal that there may be higher, hazard ratio that is positive for progression-free survival. And I think that will give us some idea to ask the question, why? I think asking the question why will help us to move ahead of how to give the best and optimal treatment for our patient. At this moment, as I said by Pasian, it remains a choice.